Welcome everyone to this month's Teach Educational Rounds. Here with us today, we have Dr. Milan Khara and Dr. Peter Selby, who will be facilitating an expert Q&A session on vaping. We are going to get started just with our land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty No. 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. I encourage everyone to introduce yourselves in the chat and let us know which traditional territory you're joining us from today. If you're unsure, you can visit the website there, www.whos.land, and I can put the link in the chat. Give me a moment. There we go. And you're also welcome to let us know something that you're doing to learn or improve your commitment to reconciliation. So we'll give everyone a couple minutes to do that. Wonderful. Thanks for sharing, Lori. Excellent. We'll give everyone a few more moments to share. Wonderful. So I'm going to keep going with some housekeeping slides for now, but please feel free to keep sharing in the chat. Let us know what traditional territory you're joining us from. And so if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you registered for the webinar and completed the pre-learning assessment. As well, make sure you signed into the webinar using your full first name and last name so we can track your participation. And then lastly, make sure to complete the evaluation and post-learning assessment that will be emailed to you by the end of tomorrow, and you'll have 1 week to complete that. And please note that a copy of today's presentation slides will be sent along with the recording as well. And so here's a little bit more information on our presenters today. First up, we have Dr. Milan Khara, who joined the Vancouver Coastal Health in 2003, having previously worked as an addiction medicine consultant here at CAMH in Toronto. Certified by the American Society of Addiction Medicine, his current work primarily focuses on treating tobacco use disorder, but also extends into other areas of tobacco control. Clinical commitments include leading the Vancouver General Hospital Smoking Cessation Clinic. Dr. Khara has also been involved in the training of healthcare professionals to optimally treat tobacco use disorder, including supporting our very own TEACH project here at CAMH. More recently, he has been involved in initiatives to combat the rise in electronic cigarette use in high schools, speaking with legislators, educators, students, and parents. He is a clinical assistant professor at the University of British Columbia. Research interests have mainly focused on hard-to-treat populations and have been published in medical journals. Dr. Khara has also been involved in many areas of tobacco control advocacy, including providing testimony and challenges to smoke-free legislation. He has also appeared as an expert witness before the Standing Committee on Health to contribute to the development of a federal regulatory framework for electronic cigarettes. So welcome, Dr. Khara. Thank you for joining us. And no disclosures to report on his end. And next up, we have Dr. Peter Selby, who is a senior medical consultant and a clinician scientist at CAMH here. He is the interim vice chair of research, Giblin professor, and director of addictions and mental health division for the Department of Family and Community Medicine at U of T, as well as a full professor in the departments of psychiatry in the Della Lana School of Public Health, and a clinician scientist in the Department of Family and Community Medicine. His research focus is on innovative methods to understand and treat addictive behaviors and their comorbidities. He also uses technology to combine clinical medicine and public health methods to scale up and test health interventions. His cohort of more than 300,000 treated smokers in Ontario is an example of his work. And here are Peter's disclosures. I'll give you a moment to read through those. So please note that the content of Teach educational rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel free to use the chat feature throughout the webinar to post any questions, answer any prompts from the presenters. To do this, you can click on the speech bubble icon in the control panel. Just ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. You're also welcome to use the reaction feature in the control panel to send a thumbs up or a smiley face throughout the webinar. That is always welcome as well. So with that, I will leave it to our presenters to take it away. Thank you, everyone, and enjoy the webinar.
So thank you, Natalie. Let's go. Do we control the slides? I'm going to try. Yep, there we are. I'm going to try to see if I can get the slides to work on my end. Oh, there we go. So three things. This is based on the questions that came at us. So I'm really pleased that Dr. Khara is joining us from London, the UK, and is able to participate in this as well. So really, we're going to take it pretty question by question and keep it sort of flowing because we had so many questions the last time we did this. We just said we'll make it into a webinar and talk about these questions. So feel free to use the chat and respond. So we want to look at the state of the evidence surrounding vaping, investigate vaping dual use with cigarettes, and potential cessation interventions. So these are the questions, and Milan, your thoughts about how you're conceptualizing this, how injurious is vaping compared to smoking cigarettes? What are the long-term health issues directly related to vaping? Are these conditions increased in severity and likelihood with dual use? And what are the health risks for youth and people who are pregnant, breastfeeding, or chest feeding? So sort of the whole, how bad is it? And what are the risks? So your thoughts.
Yeah, thanks, Peter. It's kind of funny that you can put a few brief comments onto a slide and actually have a conversation that could literally take us a number of days and probably a great deal of argument and conflict if we got the right people into the room. But you're exactly right, of course, that this is one of the big central questions around electronic cigarettes, and much of the rest of the debate sort of flows from here, because until you answer these questions, how do you begin to create your legislative framework, how do you begin to proceed some of those conversations around should we be reducing nicotine concentrations or removing flavors, or it really all stems from this and of course other questions. So to begin to reflect on the question itself, clearly this has been an evolving story for over a decade now, as these products have become more widely used, certainly in North America. And if we go back to 2015, and what most of you listening will be familiar with, which is that statement from Public Health England, which was super controversial, but kind of put a marker in the sand regarding the comparative harmfulness of electronic cigarettes versus combustible tobacco. And that statement, of course, was that e-cigarettes are 95% less harmful than traditional combustible cigarettes. Now, as I said, that's been controversial. Maybe we don't get into the weeds of that debate, but I think it's a reasonable thing to say that despite all the studies looking at different toxicants, some of the studies that have given us suggestion that e-cigarette aerosol is not without risk to the cardiovascular system and to the respiratory system, I think there's consensus that e-cigarettes are less harmful than cigarettes, whether it's 95% or 85%, or the number is really neither here nor there, but the consensus is that they're less harmful than combustible tobacco. And that may seem like a really obvious statement to make for this audience, but there is still survey data that suggests that the public don't necessarily get that, and quite large proportions of the public still don't recognize what I think is reasonably described as a consensus position. Of course, the big caveat to all of this is always, we don't really know what the long-term health issues are. It took us 2-3 decades to understand, or 2-3 decades of use of tobacco, of combustible tobacco, to see the emergence of the malignancies and the cardiovascular disease and COPD. And so if in fact vaping does carry the increase in risk of any one of a number of medical conditions, it's probably a bit early for us to know that for sure at this point. So that goes under the big kind of more research needed, not sure, unclear, which is unsatisfying, but that's kind of where we are. But as I said, there's clearly suggestion from a whole variety of animal studies and cellular studies that aerosol, that e-cigarette aerosol contains things that are not zero risk. Peter, I'll stop there, and I feel like that's kind of a bit of an opening statement, a bit of a statement of what probably everybody in the audience knows, but hopefully that sort of summarizes a good place to start the conversation.
No, I appreciate that, and I agree, I concur with you. I think what we have to help people know is that it's in whom are you talking about this, right? If you're talking about young people, yes, the immediate harms aren't apparent, but then the immediate harms from smoking aren't apparent in young people either, right? So other than getting addicted, which is both will occur with both, and feeling dependent, the immediate harm that's different than from cigarettes, that is from e-cigarettes, is the fact of risk of fire and those kinds of things, or burns and intoxications and stuff like that. Although with faulty products that thankfully are no longer common as much, but could be in certain areas depending on how people access them, is risk of explosion. So I think if we are looking at harm, we have to say under what circumstances. And I think overall, the hope is that for people who are smoking, who are unwilling or unable to quit, if they are able to switch over, then they should get some benefit. And I think, our next slide does talk about this in the literature. This paper, we can't go over all the details in it, but really, talks about what are the harms. And yes, there's a lot less of these compounds, and in short term, there are some lab evidence that there are some issues happening, but does it mean the person who is smoking, who's unable to stop, should continue smoking because e-cigarettes might be harmful to youth? That doesn't make any sense. So we need to be pragmatic about this and think about consider the person's age. What is their back years of history smoking, lung conditions that they have existing, and other medical conditions, psychiatric conditions, and then make that joint decision as to whether a switch over is appropriate. So I fully agree with you. This is not a one size fits all, which says e-cigarettes are safe for everybody or e-cigarettes are harmful for everybody. It's a nuanced kind of aspect, because the harm is not just by as a product, head-to-head comparison with the product. It's also what people do with the product and who uses the product. Okay, so let's move this along. And of course, with pregnancy, the same thing is a concern, that you wouldn't want any exposure, but there is some evidence and some studies looking at its effectiveness in pregnant smokers unable and unwilling to quit, and a lot of this work happens in the UK. But again, something to keep in mind, that the ideal benefit would be to not, but if they do, they do. So, when you look at the evidence, there's this study, which is again an association study. It's a retrospective study, which means they are looking back, and which means you cannot make any interpretation of causation. And I think if you read this paper, they are very cautious in how they interpret their own findings, which shows that dual users tend to have higher odds of cardiovascular disease compared to exclusive cigarette smokers, and no detection in e-cigarette users. And the reason why they didn't detect any cardiovascular harm in e-cigarette users is because exclusive e-cigarette users tend to be young. And I think, as you're saying, Milan, we don't know what the long-term effects are. So we can't be promoting e-cigarette use to young people if they were never ever going to use tobacco in their life. But on the other hand, what this tells me is that if I have an older person who is dual using e-cigarettes and smoking, I need to pay attention to two things. One, it may be an indicator that they are more dependent and they may need more intensive interventions or different kinds of interventions to help them stop. To educate them that the risk of cardiovascular disease is associated, this dual use is associated with more cardiovascular disease, and we just need to be careful with that. But clearly, better studies are needed in this one. So your thoughts, Milan?
Yeah, Peter, just wanted to pick up on something you said earlier, which I thought was very salient. And again, it may seem like a statement of the obvious, but in the clinical setting, we need to separate the really complex and nuanced debate about what may happen at a population level with this product, our concerns about youth and our concerns about increasing the number of people who get addicted to nicotine potentially, and more people experiencing nicotine in their brains than would have been the case if this product had never come along, and what that may mean. And these are really interesting conversations, but they're not relevant when the person sitting in front of you has end-stage COPD and smokes 2 packets of cigarettes a day, and has, in inverted commas, failed with traditional approaches to smoking cessation. If that individual is able to switch to vaping, they almost certainly reduce their personal risk. Their blood levels of carbon monoxide go down almost immediately. And so I think we have to try and remember that in our really interesting academic conversations about what happens across our systems, we don't lose that message for individuals.
Absolutely. And this is what it means, right? When you look at these kinds of studies, this is studies of the risks to the group it doesn't mean individuals in that group are at higher risk, right? That's the interpretation of population level studies. It does not apply necessarily to that individual sitting with you in front clinically. And so you have to use your clinical judgment. And Richard made a good point. In fact, it's covered in that previous paper that I showed you here. This issue of EVALI or e-cigarette and vaping lung injury, acute lung injury, which caused quite a few cases in the States, 14 cases in Canada. But as they investigated it further, it sounded like it was modified vaping products and a lot of potentially modified with cannabis oil. So vaped cannabis, as you know, is extracted often by butane and in this wax. And then when people sort of vape it, getting a lot of fat droplets. And a lot of times at that time, it was contaminated with vitamin E acetate, which is a fat soluble vitamin, which also could have been the cause. And interestingly enough, after COVID has hit, we haven't seen much of this because there are other reasons why this is happening. So, but we'd have to keep an eye out for this. And I think things will emerge as to who gets into trouble with this. I mean, think about this. Cannabis has been used by humans for centuries, but it was only more recently that the cannabis-induced hyperemesis syndrome got described, where people using cannabis end up vomiting a lot, and every time they stop using cannabis and take a hot bath, they get better. So that's how things will emerge, and with this as well, I feel. And we need to be mindful that there may be some harms that emerge. The question is, we need to make individual decisions with the people sitting in front of us in the clinic. So here's another study that I think also looks at exposure. So this is not harm. This is just what are people exposed to? And this is in Romania, where they looked at non-smokers, cigarette smokers, and e-cigarette smokers. And, it's just they looked at various toxic chemicals and what people got. And essentially that smokers continue to get exposed to a lot higher levels of pollutants that are harmful and known to be harmful. E-cigarette users don't get exposed to that as much, but they get exposed to rare earth metals like silver and other things like that. And the question is, what does that mean? But it also shows that they're also, if they're getting exposed to these things, they're getting exposed in very low numbers. So this is just a study of exposure. Cannot make any interpretation of harm. But and notice in this they didn't have dual users, so we don't know there. But those are the studies that to answer those questions that came up. Okay, so if there are other comments around harms, put them in there. And one way in which we look at if people are going to go with a vaping device, then try to use a vaping device that's not modifiable. Ideally, a closed system, pod-based system that doesn't have a lot of exhaled vapor that comes out of it, and so those are, and get people not to tamper the device in any way, and of course use it in such a way that they don't land up using things that have flavorants that can cause harm, like diacetyl or things like that. And stay with the legal 18 milligrams or less, and try and only vape outdoors and separate it out from other activities, and don't get into a grazing behavior with vaping. So that is generally how I approach sort of if that individual is going to switch to vaping, do it exclusively, and then this is the kind of product, and then periodically look at tapering down or coming off completely when they feel ready to do so, but don't push them to do that, and monitor for relapse and prevent relapse to cigarettes. So there's lots of stuff in the chat coming in. And I guess you're in the UK, and so Leslie is asking, has the prevalence of smoking in the UK declined significantly since the arrival of e-cigarettes? Has there been a corresponding decline in the rate of lung cancers yet, or it's unknown or too early to see? So, I mean, lung cancer is too early to see. It's, you're talking about 15, 20 years after. So, but do you want to hazard an opinion on the, rise of e-cigarettes and drop of smoking? And
Yeah, Peter, it is interesting being here in the UK. For anybody who has visited recently, one certainly notices that the use of e-cigarettes is pretty rampant. The classic numbers of people outside pubs smoking really has been replaced by large numbers of people using e-cigarettes, and it's hard to get away from the feeling that something, that there is this kind of pretty major shift away from combustible to e-cigarettes in this country, which would not be surprising because, of course, the UK government has been really promoting that for more than 5 years now. And another thing that caught my eye was that one of the major retailers of pharmaceutical products in this country, Boots, which is the biggest high street chemist, actually has e-cigarettes on the wall alongside NRT, and the big banner above is not smoking cessation products, but is smoking alternatives. We're just not seeing that kind of landscape in Canada yet. So clearly, the UK is different. If you look at some of the youth use data of the last few years, they haven't seen high numbers of they haven't seen the amount of youth use that has been seen in the United States and Canada, and that's also interesting yet, anyway. And to the question that was posed about, has smoking prevalence gone down? Well, smoking prevalence has gone down, and it does somewhat mirror the rise in vaping in the United Kingdom, but that still, I think, doesn't allow us to make a direct association between those two facts, because of course there's clearly a whole bunch of other tobacco control policies in play, and it's a bit early really to be able to say that because vaping has taken hold, that's why smoking has gone down. I suspect it's clearly part of it, but again, a bit early to really understand the relationship. What's your view on that, Peter? Do you have a take on what's been happening with prevalence rates in the UK?
Well, I think that it's the same issue that I think that's happening in the chat as well, and there's this observation that in countries which have had nicotine-containing e-cigarettes, you've seen a reduction in smoking rates and uptake of smoking, but that trend in reduction in smoking had been going on. It may have seen a little bit of a bump in Canada in 2020, but it's gone back down, and of course in Canada we have this issue of this difference in the prevalence depending on which survey you look at. So the truth lies somewhere in between, and I think what we can say is that traditional tobacco control has certainly pushed smoking prevalence down with respect to fewer people taking up smoking. But also, if you look closely, what seems to have happened is we've pushed smoking onset to beyond 18. And so we still need to think about the product that people are using. And overarching, if you have a product that has less exposure to toxins, you would want that to be a replacing cigarette. So at a population level, you may land up with less harm because you're now, so I think that the experiment in the UK is an interesting one. The fact that they're listed on their formulary and allow people to give it out. So I think, as Calliope said, that as a pharmacist, you'd want to give it to your patient, but in Canada, there isn't a framework. I mean, there is a framework, but there's nobody's going to ever do the study in Canada to get a official indication for an e-cigarette to be a smoking cessation drug when you can just sell it, or without any claim. And so and currently we can't study it even as an independent investigator because we just don't have the kind of to meet the regulatory requirements, we won't be able to do it. So, so yeah, and will their products be deemed dangerous over time? Absolutely. I mean, you know, and it's very hard. So and Marilyn asked a question: is could this be leading to Alzheimer's? Here's the problem: e-cigarettes were first made their, you know, entry in 2007, but none of those products are on the market anymore. So, and there have been rapid evolutions. All e-cigarettes are not the same. And so, and all of the people, at least initially, were initial smokers. So, and smoking harms can manifest themselves 20 years after. So it's, you know, of course, cardiovascular harms will drop in a year, but other harms continue to, like especially cancer harms, take a while. So I think we need to pay attention to what's happening in the UK. I think it's an excellent opportunity to understand, right or wrong, just like how people are looking at Canada for the legalization of cannabis. It's not perfect, you know, and there are people who come to harm from it, but overall social harms have dropped. So, you know, so it's a trade-off in society. What do we do? So I think it'll be interesting to see what happens in the UK. So, you know, let's get to some of the questions. Yeah, people wanted to less harm exposure to, yeah, because of, you know, the vaping concentration in the outdoors is a lot less. And the question, I don't know if you know this, Milan, is the maximum allowable nicotine concentration in the e-cigarette lower now? I thought they were always 20 or less, but maybe I got it wrong.
No, that's correct. I think the EU, when the UK was part of the EU, determined 20 milligrams per mil as their upper limit, which of course we have more recently followed. So I'm not sure that they ever had the 57 milligram per mil product that was available in North America. I don't know if anyone's aware of that, but I think they dealt with that much earlier.
Right. So, you know, the question is about youth vaping, right? So if we have youth, so first of all, what is youth vaping? Is it ever use? Is it last month use? Is it regular use? Is it, you know, and here's the thing, as you start seeing youth getting into using something daily and feeling like meeting that criteria for addiction, chances are they've got something else going on as well. It's not to say that they aren't addicted, but just pay attention. You don't just look at their vaping, you need to look at all of them and see what's happening. So, and at a population level, you know, this is a societal issue, right? Do we want youth to get addicted to nicotine for the long term? And let's say they get addicted to vaping and they just stay with that and don't get forced to switch to cigarettes. You know, what is the harm that'll come to them? We don't know. But we know it'll be a lot less than if they went to cigarettes. That's what we can be fairly certain about, just because from an exposure perspective. So, you know, that's the $1 million question as to, you know, are we okay with higher nicotine dependence or lower cigarette dependence in our young people, and are we willing to do that to them? So I don't think anybody has an answer. Everybody feels that no, you shouldn't, you know, sacrifice our young people because you want to get adults to quit, and so we need to think that one through a little bit more. So let's come into this vaping cessation psychosocial approaches. Recommendations for adults, youth and young adults, and ways for them to track the nicotine content, how they vape, etc., and a trauma-informed lens. So, Milan, your thoughts?
Yeah. So of course, Peter, I think the next slide actually it provides kind of the state of the art in vaping cessation, and the state of the art is rather disappointing because, of course, there's not a ton of evidence, and of course the very nice vaping cessation product that CAMH has produced really opens up the product very well by saying that, look, we've taken most of what we recommend from the principles of tobacco cessation in the absence of of really very much research into the kinds of questions that are on this slide. You know, how do we do this? In my clinical setting, when we see people who vape, we are literally doing exactly that. We're providing them with behavioral counseling, which is based on the kinds of approaches we used in those who use tobacco. For those who are ambivalent, we're using motivational interviewing. For those who are ready to stop, we're providing them with skills training and support, and we're using the products, and we're using all of them. We tend to have a bit of a preference for using short-acting NRT initially, just because it's difficult to know at what level we enter. But we're I think right now we're using a not the approach that we use with tobacco users in those who want to quit vaping, simply because we don't have the evidence to really inform how we do this. And I know that's frustrating for people who pose these questions, but I think that's where we're at.
Yeah. And clinically, you know, what I tend to do is really try to get people to track their vaping and isolate it from other activities. Really, the biggest problem I find is this grazing behavior where people are taking 1 or 2 puffs every few minutes while they're engaging in their daily activity living. And what I try to get people to understand is that nicotine is a reinforcer of all activities. So it'll get conditioned to whatever you're doing. If you just keep doing it with your computer and you're sitting in front of the TV and you're eating your breakfast, and if you're just bored, and so really isolate the behavior to episodes of vaping, as opposed, which, interestingly enough, many of my patients will say that they found it easier with cigarettes because they knew they had to, wait till they could take a break and leave outside. So that norm of not vaping, of not smoking indoors, many ways help them control their smoking. And so what I talk about is that, look, if you go back to first principles of behavior, it's the opportunity to engage in the behavior that allows the behavior to occur. So reduce those opportunities and make the rules about making your living space vape free, etc. So I get them to track. I get them to make sure that they write down what concentration of nicotine they're using. And sometimes it's confusing for people because it comes in percentages. There's no standardization. So to get that, and what I warn them is not to do a calculation, say, oh, I'm using the 18 milligrams or 20 milligrams per ml, therefore I'm getting this amount of nicotine, and therefore I'm going to use a 21 milligram patch or whatever because that's what is delivered. You have no idea what is getting absorbed into the system. And so you have no idea. So I agree with you. We use the same kind of approach of go with short acting or use something, the oral medications for this population. And then, trauma-informed lens is always a trauma-informed lens, right? But we don't have the evidence that adverse childhood experiences are the root cause of vaping, right? We know that there is, at a population level, experience of adverse child experiences are associated with doubling the odds that somebody will become a smoker and doubling the risk of them developing COPD and a whole bunch of other things. But I think you need to separate that question out into 2 things. In general, we need to apply a trauma-informed lens to people who use tobacco because there's often that's happening. And we should basically applying it to everybody. It doesn't matter if, you don't treat your people who are drinking alcohol with a, other lens. It's like, or somebody who comes in with any other condition, what's happened to people determine their health. So pay attention to it. The issue of ACEs, the evidence is not there right now with root cause of vaping. And one of the things that I think we also go back into when we're doing these root causes kind of thing, in a Western mindset, eventually it always comes down to the individual. And as we've seen with tobacco and we are seeing with this, there are a lot of social and financial and other drivers at play that are driving the consumption of these products. I mean, that we live in a capitalist society. If you don't consume, our economy comes to an end. So So you have to pay attention to that, because that is the biggest driver of human behavior. The biggest, follow the money, and then you'll see it. And I think, Lori put up the unsmoke, and you can see how the industry there is trying to ride this wave and create confusion, because we've talked about e-cigarettes, but the tobacco industry's come out with heat not burned. And think about how perverse that is. You've got a potentially safer product which has nicotine in it and doesn't have tobacco, but you still put out a product that interferes with that. Why do that? It's like saying, okay, we have the car has 8 airbags, but guess what? Because we want to give you a choice, we'll only sell you a car which has 1 airbag, and that too on the driver's side, on the passenger side. Like, that makes no sense. So if we're going down a harm reduction sort of line, it's really disingenuous for these companies to want to talk about this or moving Canada towards a smoke-free future. But it's very simple. If tomorrow you got rid of all combustible cigarettes, the 5 million Canadians who smoke will, some will quit, many will quit, and some will switch to getting nicotine through vaping devices, and you would have essentially got a smoke-free future. It's very simple. Just stop selling these products, and you will have it, right? Just not available anymore. It's just like how you had unleaded gasoline. People still drove. They just got leaded gasoline. Yeah, they got unleaded gasoline, right? The industry had to do it. So this is very, this is very disingenuous of them to put this up there when the whole issue is they could take it off the market.
So Peter, I think that's a question that was raised by Richard in the chat, and
right.
And I think that's exactly right. That's where this ends. That at some point, governments and the people decide that why would you be able to sell lethal combustible tobacco if you're telling us you've got a great alternative? And I don't know how far away that is, but presumably that's where this thing ends, and there'll only be e-cigarettes available to us, whether it's a decade or 5 away. I think that's where we're going. What would you agree with that?
I mean, yeah, but I think in the first time in Canadian history, we have seen Health Canada recalled cigarettes, which is the most bizarre thing that I have. I mean, only in Canada, right? They recall cigarettes for Viceroy Full, because they were immediately stopped using the recall products and contact Imperial Tobacco because they do not meet the performance standards, because they should burn to their full length no more than 25% of the time. And it's saying that these are not meeting the performance standard and pose an increased fire hazard. But hello, this is most bizarre. So I think we've got a regulatory weirdness in Canada that is often driven by the industry, and governments have given into them. But here's the ridiculous thing: we call cigarettes because they are a fire hazard. Only a subset, because they burn faster or whatever. They burn out too quickly. So I think we've got to really step back and pay attention to our overall approach to people use of substances, right? It's like, you think about it, you have a supervised injection facility or consumption facility, but they are smoke free. So people have to smoke outside, go in and shoot up the illicit drugs they bought. It is completely bizarre of how we've approached this, and we don't have a rational approach to substances in this country at all. So anyway, we diverge. We want to come back to the vaping cessation, but it is an important diversion because we do have, here we talk about other people saying, could we get a safer supply of other drugs, and could we get harm reduction? We've got all that in tobacco. We've got the cleanest form of nicotine and nicotine replacement. But again, we haven't made it in an acceptable way. We've got vaping as a potentially acceptable alternative, but we completely do everything to legally promote the more harmful delivery device. So this is really mind-boggling to me. Okay, moving right along. We have as I think you referred to, as we came together to create this vaping cessation guidance. Thank you to the Ministry of Health in Ontario. They and the government of Ontario, they asked us to put this together. We brought a whole bunch of international experts together because there's no randomized controlled trials to talk about. So we had to come up with expert opinion. And one, there's lack of evidence to support effective vaping cessations primarily, and we have to apply what we've applied from tobacco to this, and that's what most people are doing right now, and hopefully in time we will need to do that. How effective is it to tailor interventions for vaping for different populations? We don't know. But so therefore, these are general guidance and have to be adapted by or with specific vulnerable populations. And I think in this situation, what we're saying is when intervening with somebody who's vaping, do so cautiously. Don't be dogmatic about what you're telling them to do because we just don't know. And definitely consider people's social and cultural diversity. And in general, use a trauma-informed person-centered approaches essentially in any case, but we just wanted to reiterate that this is no different. Don't freak out on people. So actually, before we leave this in the guideline, what really came up in this in the Delphi panel with experts was nobody could agree with whether this should be called vaping addiction, vaping dependence, nicotine addiction. We could not, over a couple of rounds of Delphi panels, we could not come up with a consensus. What does this tell us? This tells us we need to do better research in defining this behavior and classifying it and proving that in fact it is an addiction versus a behavior where people are engaging in something. So that's for scientists and for all of us to figure out as scientists, because there's a big risk if we start calling something addictions when they aren't. So, for example, there are conditions that are been trying for years to show they are addictions, such as food addiction, but the evidence just doesn't add up for making that evidence at this point. So we need to do the science, and until then, we should be cautious about how we refer to people who appear to be addicted to vaping or vaping regularly, and be careful with the language we use. And that's why I think that trauma-informed approach gets us to be very careful. Milan, your thoughts about this?
Yeah, no, I think you've summed it up very well, Peter. I think we don't entirely know the trajectory of these young people, right? We've understood the trajectory of those who experiment with tobacco in their early teens. We know that a very significant proportion of them will become addicted and will have lifelong struggles with tobacco. We understand that trajectory and the numbers of people who will face this lifelong struggle quite well because we've been studying it for almost 100 years. But we don't actually know what's going to happen to the young people that we know are experimenting with vaping in quite big numbers. They can go down one of a number of roads, and we speculate that may well be the cause. We worry about them transitioning to combustible cigarettes. We wonder whether they'll just stay vaping, but they may actually also just stop. We in our clinical settings, we're seeing people who are struggling to stop, but we don't really know what the population of young people who are vaping are actually eventually going to do.
Right.
So we do need to be careful when we're thinking about this in inverted commas, this disease entity that we of course are ready to jump in and treat as a medical disorder, because that's what we do. But there are certainly some question marks.
So as we're doing this, I know we have only about 10 minutes, so I want to make sure we get here. And no large-scale studies, so that's a quick, easy, no large-scale studies. What is the recommended NRT dose? I think we covered it. Be careful, start with, figure out if the person brings in their product if you can, or at least shows it to you on if you're doing a virtual assessment. Make sure it's not, and we've been cautiously starting out with, if they meet those criteria, look, they're waking up at night to vape, and they can't go a few hours without vaping, and they get into withdrawal symptoms, and you use the Minnesota withdrawal scale, and you can say, yeah, this person's going to nicotine withdrawal. You could use a patch, but even then, I would go lower a dose on the patch and use combination with some short acting. Preferably, I like to use varenicline or bupropion because it's irrespective of the dose of how much they're using, it'll work, and it won't cause them that amount of harm. But there's a lot of preference to switch to nicotine. Also, I help people taper down. Become more mindful about how they vape and continue to use less and less of the same concentration, and then drop down from 6% to 3%, and then down to 1 or 0. So depending. So there are many ways to do it. I don't think there's any consensus on this. Lots of concerns about dual use, but unless it's a transitional phase. So if people are transitioning from, and you're just doing a cross section, that's one thing. But really, you want them to commit to exclusive vaping. And again, similarly with youth, make sure they're actually dependent, right? Because kids with a lot of things, even with cigarettes, would say, yeah, I'm a smoker, or I don't smoke, and they're actually dependent. So you need to ask about symptoms of withdrawal and tolerance. And I often ask about intoxication as well, because some youth don't recognize that they're over vaping. So they're getting nauseous and headache and jittery and having a slow heart rate, and they don't recognize that as being intoxication. So that's the people. And with pregnant and chest feeding, we have in the guidelines, all bets are off. I'm just going to push us ahead a little bit, Milan, if that's okay. And smoking cessation by vaping, it is an effective way to quit smoking in the UK, at least, and the trials have come out there. And I don't know if you use this with your patients, and who do you use it in?
Yeah, so absolutely, the primarily UK evidence, the Cochrane, I think, of 2021, and the HAJAC study that was published in the New England Journal of Medicine, really quite clearly stating that vaping is at least as effective as NRT, if not more so. But I think the way we should read the evidence is that it can be one of our options. I don't think we need to be throwing away our first line proven treatments that we know are safe. But I certainly will recommend vaping as an option for those who are not succeeding using those first line treatment options. And sometimes people will come along themselves and say that I'm planning to vape to help me to stop smoking. So it increasingly is one of the tools in our box, but we certainly use it with some care, not least because the next question after you say, well, have you considered vaping to try to help you quit smoking, is, well, which device and how much, and and sending somebody off to the vape store to be advised by a young man in a Motorhead T-shirt or whatever, it's uncomfortable for us as medical professionals, I guess. But certainly it's an option that for those who seem like nothing else is working, should be encouraged.
Yeah. So I think these are these are important things in the chat as well coming up. So if they're quitting, quit both. They can try quitting one after the other, but I tend to tell people, look, you're quitting nicotine, quitting nicotine. But if you want to switch over, I try to get them to switch from cigarettes first to vaping and then off, unless they are finding that I have had patients who say, no, with vaping, I can't, I'll end up grazing, whereas with cigarettes, I know I have to go outside. All these other environmental things make me use less. So I find it better that way. And then I'll say, okay, I'll work with them. So it's really, you got to work with the client, what works for them. And of course, the cost savings. Now, I can tell you, I recently had she's a patient in her late 60s, has COPD, long-standing bipolar disorder, tried everything, first line, second line. I think I even tried nortriptyline with her, but not able to stop. And we were able to get her to switch over to vaping. And she quit for a month, but relapsed. Why? Because in her neighborhood, the local dealer of contraband cigarettes acted like any other dealer, lost a customer, started giving her some freebies, and were basically preying on the vulnerable. So she relapsed. But and then the cost saving, because the cost of contraband is like nothing, right? Compared to that's the cheapest. So we've got to do a better job in figuring out how contraband doesn't make its way into the hands of vulnerable individuals such as her. Because it is that's where the benefits of vaping get lost.
And
okay.
Peter, can I just add
Yeah.
add a point to that? I have to say that the UK studies, the Cochrane, quite impressive in concluding that e-cigarettes are arguably more successful than NRT in smoking cessation. But I have to say that actually in my own clinical experience, that's actually not been the case. So invariably, the folks who we end up having the vaping conversation with are those who have failed first and second line treatments, and then they also tend to fail with vaping as well. And I think what that really reminds us is that the reason they're failing with first and second line treatments is that they're highly dependent.
Yeah.
And they're not failing for want of a magic bullet that we just haven't offered them. They're failing because they're hard to treat because of their comorbid conditions and their 50 years of tobacco use. So as much as it should be available as an option when we're running out of options, my own anecdotal experience is it doesn't often seem to be a magic bullet that comes along and saves the day.
Yeah. So for people who aren't from Ontario, on our website, you can find the lower risk nicotine use guidelines to help people who want to make this this switch over and how to use it. So that's it. And we don't have time for other questions, but I think we went along with the questions in the chat. And medical directives, I think Richard asked, I think we got to think about that, about how that happens. I think it's an institution as to whether you can delegate that over, but certainly pharmacists can initiate it. So I think it's, and NPs don't need a medical directive to do this. It's within their scope. So pharmacists and NPs should be able to do that. If you need to get in touch with us, here's how you get in touch with us. But of course, if you have questions, you want to join our listserv, the Teach listserv, please continue the conversation there. And over to you, Natalie. Thank you so much. And thank you, Milan, for having, taking time out of your beautiful day in London to be with us. And and say hi to the Queen when you see her.
Will do.
Yeah, thank you so much, Dr. Khara and Dr. Selby, for such a great discussion. And thank you to our audience for being so engaging. It's been a wonderful webinar. I know we are out of time, so if you need to head out, feel free to do so. I'm just going to go through a few housekeeping items again to end off. So just a reminder, a link to the evaluation and post-learning assessment will be sent to you by the end of tomorrow, and you'll have 1 week to complete that in order to receive your letter of completion. As well, along with that will be the presentation slides and the webinar recording if you would like to watch it again or send it to a colleague. As well, I just want to take the time to let you know about our next upcoming Teach educational rounds on July 13th on risk assessments with youth and young adults. Registration for that will be opening up next week, so stay tuned to our website or Teach listserv or Teach mailing lists to hear about that. And if you missed a portion of today's webinar or would like to view it again or are interested in seeing a previous Teach webinar, an archive list can be found on our website. That is all for now. Thank you all so much again for listening and participating today. We hope you have a great rest of your day. Bye, everyone.